And I'll be how we use the behavior change wheel to develop an intervention. Okay. Background, I'll introduce what the health problem is, and then justify or rather explain briefly about implementation science and the behavior change theories and implementation science frameworks, and then justify why I decided to go the direction of the behavior change wheel, and then describe the intervention design process that I went through, and end by presenting the theory of change. And hopefully during the Q&A session, we can have other members in the audience who've had experiences using the behavior change wheel sharing. I'd hoped Mike would be, but he's just excused himself. He has an admin meeting. I don't know if he's in the audience or anyone else who's used the behavior change wheel or the theoretical domains framework. We'll be hoping you can also share from your experience. These are the leading causes of death. And actually, before the ongoing pandemic, it was the leading cause of death from an infectious disease cause. It has since been overtaken by COVID-19. More than 1 million children fall ill with TB every year, and there are approximately 200,000 in children every year. However, 60 to be infected, and these children are at risk of progression to active disease. So TB is known as a hidden epidemic, especially in children, because approximately 60% of them go undiagnosed. And what is really sad is 90% of children who die from TB were actually never treated. And this is actually tantamount to neglect. If you consider TB is an age-old disease, it's been with us for over 100 years. It is actually preventable and curable. So misdiagnosis is actually a failure in the system. And one of the greatest challenges is the difficulty in making a diagnosis of TB in children. So this schema is just to show that even there are million cases who end up being diagnosed and notified every year, they just present a tip of the iceberg. A lot is going on under the surface. They could be dying from other after being mislabeled as having other diagnoses or going unreported. So a bit about the diagnostic challenges, because it's in. So the signs and symptoms of TB are fairly non-specific. We talk of the cardinal features of cough, fever, weight loss, and lethargy. And cough and fever are the single most presentation of illnesses in children, so very ubiquitous and non-specific. And TB mimics many other childhood illnesses, mimics pneumonia, which is the leading cause of death in children, mimics HIV, mimics malnutrition. So healthcare workers need a high index of suspicion to even be thinking about TB in the background of these symptoms. Then the diagnostic test that we have, for example, like the chest X-ray, is fairly non-specific and riddled with inter-observer variability. If you show this film to 3 different experts, they may give you 3 different opinions about what is going on in this film. And then tuberculin skin test that has also been with us for quite a bit of a while. In Kenya, where I work, is riddled with sporadic supplies. Actually, from the entire time I was doing my PhD, we had fewer than 100 tuberculin skin tests being done in the hospitals I was working in. And even when you get it, the tuberculin skin test itself also has low sensitivity and low specificity. And on its own, it cannot tell you that a child has TB. When we come to the bacteriological test that we've had available for years, so we've had the sputum and culture, and because of the nature of the disease in children, the yield of bacteria is very low, and these tests often end up being negative in children. And the other challenge is actually getting the specimen from children. You and I have tussive cough. We can cough and produce the phlegm for specimen testing, but children tend to swallow their phlegm. So to collect it more often than not, you have to use fairly distressing methods, and you need a fair amount of skill, competence, and courage, I dare say, to collect this specimen in children. So bringing TB care into this whole issue of quality of care issue, Kenya is one of the 30 high burden countries for TB in children. And children represent less than 10% of the cases. The issue of in the community case detection, right from the community. My focus was in hospitals because this present like low-hanging fruit. They are already in the system. They already have signs and symptoms, and they hope to access diagnostics and care. The prevalence survey that was done in Kenya in 2016, however, showed that 75% of people who ended up being diagnosed with TB had actually presented previously in a health facility, but they were never diagnosed. Remember, this was a prevalence survey, so they were going door to door trying to identify TB cases. So a lot has been invested by the Ministry of Health and other development partners to avail evidence-based guidelines. We have availability of Gene Expert, and it's a molecular-based platform that is an improvement from smear and culture that I talked about before, which has better sensitivity and specificity. And the results are supposed to come out within 2 hours compared to culture that would take up to 6 weeks for you to get results. And by the time I was doing my study, there were close to 200 Gene Expert machines spread out all over the country and more consistently being sourced. A lot has also been spent in training healthcare workers. At the time of data collection, up to 600 healthcare workers had been trained specifically on pediatric TB. But we still have this case detection gap that is ongoing. And the one that is of concern is what I've highlighted in green, of these patients who present to health facilities but remain undiagnosed. And with the world trying to move towards ending TB by 2035, if we don't capture these patients, then we'll consistently have a pool of cases who will continue transmitting the infection if they survive. And healthcare workers are key in trying to close this gap of patients who present to health facilities but don't get diagnosed. So bringing back now why I came to implementation science and behavior change theories. So we've seen considerable efforts have been made to introduce and scale up evidence-based guidelines and new technologies to a diagnosis of TB and the gaps that still remain. Now, implementation research is a scientific study of methods to promote systematic uptake of research findings and other evidence-based practices into routine practice. And this is with an aim to improve the quality and the effectiveness of health services. And it includes the study of influences on healthcare professional and organizational behavior. So there are wider system issues, and the wider system issues probably need a lot more resources to solve. If you think about case detection right from the community level. But we also recommend the patient in hospitals. They are key in diagnosing and utilization of available interventions. Like Gene Expert was shown to be very effective in research settings, but has not been performing as well in practice. So we have interventions that have been shown to be effective in clinical trials, but the scale up and adoption and utilization has not been as expected. So changing the behavior of healthcare workers need one to understand the factors that influence their practices. Why do they do what they do, so that we can design appropriate interventions. And now this led me to the murky world of theories. And a theory is just a set of analytical principles designed to structure our observation, understanding, and explanation of the world. Theories are supposed to help us identify the mechanisms of change, understand which elements, for example, in an intervention are necessary and work together for effective adoption and scale up. And this is in reference to health service interventions. So it's good practice to be explicit about the use of theories when designing interventions, because in literature you'll have lots of interventions being described, but people have not been explicit in trying to describe how these particular interventions work in practice. So you'd say, for example, training or, I don't know, use of guidelines, but not being explicit how they're supposed to work. And then when you try and use the same interventions in your setting, then you don't get the desired effect. So use of theory is supposed to help guide, explain why particular interventions work or don't work. A range of theories to choose from, varying disciplines: anthropology, psychology, behavioral sciences, lots and lots. And Iklis, who I think is probably the father of implementation science, says the choice of theory needs to be pragmatic and most applicable to stakeholders. I don't think there's usually a right or wrong answer, as long as you can justify why you used the approach that you did. And you've been able to examine the theory itself, its concepts, the logical consistency, generalizability, and parsimony. Has it been tested before, and is it useful in your context? Now, to make matters more complicated, a lot of times you have to really acknowledge what your own position, your philosophical standpoints are as you're doing your research, because that will influence heavily what approach you end up using. I myself have a medical background and epidemiological training, so I was coming from that end of really more deductionist. But after interacting with my work, I've learned to be more pragmatic in my approaches. And that will probably explain why I ended up going the way I did. Somebody else looking at this question would have used a totally different approach. And I'm learning that's also okay, as long as you can justify why you did what you did. I thought it useful to just mention in brief some of the common behavior change theories in public health. Behavior change theories, I mentioned, there are like over 100 of them as per what I had been reading around so far. So I've just tried to identify some of the common ones you might come across in public health, hoping this might be useful to someone who's starting out and is trying to think about what direction to go. So the social, and I won't go into details, I've provided references if you want to read more towards the end. So social norms approach sort of has the assumptions that individuals often perceive that their attitudes and behavior are different from those of other people, but when in reality they tend to be similar. It said, look at the 5 people you spend a lot of time with, and more often than not, you're a lot alike. So perceived social norms can be used to influence behavior by trying to see how you can get a particular group to adopt a certain thing as their social norm. And then there's the cognitive dissonance approach. And human beings prefer when our beliefs, attitudes, and behaviors are aligned and consistent. So any inconsistency will force us to either change our attitudes or change our behavior so that we avoid this internal conflict. Then another interesting theory is the default option, whereby you present the desired option as a default, meaning what you get if you don't actively make a choice, and this will increase the chance that it will be chosen. And if you think about the behavioral theories underneath, is that defaults work by creating a perception of ownership, because it works in the principles of pleasure and gain. So the pleasure we derive from gains is less than intense from the pain of an equivalent loss. So we now try to the default. And then things like choice architecture, manipulation, where you try and reduce the number of choices the more choices that people have, the less likely that they'll choose any option. And then very important is this issue of sense of control, making people responsible for their everyday choices. Now, these theories have a single factor, sort of like they're very unidirectional and a bit linear. And then these other theories in this slide are more multifactorial. So you may have come across the health belief model, for example, in campaigns in trying to stop smoking or helping people reduce weight. And the assumptions are when you try and think about people's what they perceive to be their susceptibility and risk. If I smoke, am I susceptible to getting a particular adverse event? And can I do something about it? Their perceived self-efficacy. What cues for action are there? Are there billboards everywhere that are glorifying smoking or showing the harmful effects? And then you may also have come across theory of planned behavior because it's very commonly used. And the principle is just basically around self-efficacy. Do they believe in their own ability to perform a behavior? And the premise is that behavior is predominantly influenced by conscious thought. And then you may also come across the health action process approach theory, where they believe that behavior can be achieved through a structured process. First, by identifying what their motivation is, establishing goals, and then now planning and acting to achieve these goals. Another multi-factor approach theory is the stages of change, and it's a trans-theoretical model with the 5 steps listed there, from pre-contemplation, contemplation, preparing for action, and then maintenance. And they premise that behavior is only influenced through consciously contemplating change. So you really need to make a conscious effort to change, and they need to be ready for this to happen. And then there's the combi model that has the premise that behavior comes about from an interaction, from people's capability to perform the behavior, what opportunities they have, and what motivation they have. And in this particular approach, self-efficacy is very important, but they also appreciate the role of larger social structures, like things like policy in the outer setting that contribute to individual behavior change. Again, so lots of theories to choose from. And if the more you read around them, you start to see some things, some common threads underlying things to do with efficacy and goals and trying to get into habits. So I guess it's just trying to see what best suits whatever question you're trying to answer. So just a bit on the combi model, because it's what the behavior change wheel is based on. And I mentioned the idea about capability, and capability is both physical. So physical has to do with things with strength, sometimes the skill, sometimes even the stamina to perform a particular action, and then psychological, the knowledge, the competence, memory, and then opportunity has to do things with the environment that affect one's ability or capacity to perform. So when you think about physical opportunity, do they have the time to do this particular action? Do they have the resources? Is the particular setting structurally enabling them to perform this particular action? And then if you think about social opportunity, what are the interpersonal influences in play? What social cues do they have? And then motivation, reflective, to what extent their beliefs, intentions, and choices, or automatic motivation. And this is the desire, actually, if you want behavior changes, to get everything into the automatic realm where things become habitual and almost ritualistic, that they don't even really think about it while performing. And this schema just shows how they interact with each other to influence behavior. So those were theories. Now I'm going to talk a bit more about the frameworks. And I really recommend this paper by Per Nielsen that helped me now when I was trying to unpack all this, making sense of implementation theories, models, and framework. So we've seen what theories are, just trying to understand and explain phenomena in the world. Yeah. And then models, like Combi model, it's now like a deliberate simplification of a phenomenon. They are closely related to theories, but they have a more narrowly defined scope of explanation. So tend to be more descriptive than explanatory, whereby theories can be both descriptive and explanatory. And theories can be, like high level, like program or grant theories, or mid-range theories, or lower range, where now lower range theories may not really be generalizable to wider settings. And now frameworks denote structure, overviews, or outlines consisting of various descriptive categories. So various concepts and constructs coming together with showing the relationships and in an attempt to describe a particular phenomenon. And in that paper, they try and give guidance, like depending on what you're trying to do. So if you're trying to describe or guide process of translating research into practice, for example, there are process models you can use. If you're trying to understand or explain what influences implementation outcomes, you can choose determinant frameworks. There are classic theories you can look upon, or implementation theories. And then if you're evaluating implementation, then there are evaluation frameworks as well. So again, these are some common implementation frameworks that I came across in my reading. The list is not exhaustive, but I thought this may be relevant to health services research. And again, I've provided references to if you're interested in reading more, and some of you may have already come across them, like the Consolidated Framework for Implementation Research is commonly used. It has 5 major domains as listed there, and the intended purpose is like diagnostic assessments of implementation context, or evaluating implementation progress, and to help explain findings in research studies or quality improvement initiatives. So if that's what you're trying to do, you can try and see how others have used this framework and see if it suits your purpose. Then diffusion of innovations is also a very common framework. It's meta-narrative and multidisciplinary. I mean, you can see all the disciplines listed there, all the way from economics to communications, technology, and management theories. Some of the disciplines that lend to this particular framework. And intended purpose has been to just have a model for considering the diffusion of innovations in health service organization. What factors influence the spread of once something is being used and then now the scale up, and provides a robust and transferable methodology for systematically reviewing complex research evidence. And then you may also have come across Carl May's normalization process theory. It's an action theory basically concerned with explaining what people do. The constructs are listed there, and he designed it as a sociological toolkit to understand the dynamics of implementing, embedding, and integrating some new technology or complex intervention. And you can read around what others have done with this framework. And then you may also come across the Paris framework, also a planned action theory. And it just was designed to guide implementation strategy and a model to describe and explain how change occurs. And then lastly, we have the theoretical domains framework, the TDF, that's based on various psychological and behavior change theories, actually 33 theories and 128 key theoretical constructs related to behavior change, and synthesized into a single framework. The domains are listed there. The purpose was to simplify psychological theory and make it accessible to those in evidence-based practice. And the attraction for TDF is also, it was designed to help inform intervention design for behavioral problems. So beyond just assessing, describing, and explaining, they give you an opportunity to design intervention. So which direction did I go? If you remember, my aim was trying to explore the reasons for the gaps in case detection and utilization of diagnostic tests for TB in children to design an appropriate intervention. And in the course of my work, I recognize that individual and collective behavior change are key to implementing new practices and to improving health outcomes. So I went with the behavior change wheel that was based on the theoretical domains framework and the COMBI model. And the strength is that it naturally incorporates context in the design, and it's key to effective design and implementation of intervention. Context is always important. And yeah, theoretically sound, like I've explained, and has been validated in hundreds of studies, both in health and other sectors, and was developed to simplify use and make theory usable by other disciplines that may not have as much exposure. So that was really perfect for me. So these were my study aims: to describe the epidemiology of childhood TB in Kenya and use of diagnostic, to determine children who are being admitted to hospitals who have evaluation for TB that is consistent with the guidelines, and to explore influences of TB case detection in children, and then to use this empiric data to see how understanding of theory linked to now understanding of context will design an appropriate intervention package that may help. So yeah, these are other published papers that I can provide linkages to, because I don't have the time to go into the detail of this. The focus is going to be on now the intervention design. So in the next few slides, I'll be talking about how I use the behavior change wheel to aid the intervention design, and that's the behavior change wheel over there. The core is formed by the COMBI model: capability, opportunity, and motivation. And then surrounding the core are interventions, which mainly target interventions. And this include education, persuasion, coercion, training, and the like. And then at the outer level are interventions that act at policy level. So for example, guidelines, legislation, regulation, and on and on. And the wheel just shows how they are potentially linked. So for example, interventions targeting capability and are around, and then the policy interventions are in the outer core. And I'll do my best to illustrate how I did this, but just putting out here, there's actually a textbook that I got, the behavior change wheel, that guides you in the steps of designing this intervention. And the authors of this approach run a course every year at UCL, which I also attended and I found very useful. And yeah, if you go to their website, they have more worked examples and what have you. Like this particular PDF shows how local government and people in policy can use the behavior change wheel to design simple interventions and even fairly complex interventions. So if you forget everything else, this is a useful summary slide. You start from behavior selection, which just goes to identify behaviors to focus on to meet policy or objectives. Then you do a COMBI diagnosis, identify out of capability, opportunity, and motivation, which aspects are to target in order to change your behaviors of interest. And then you select intervention types. Again, these intervention types will be guided by what COMBI diagnosis you are able to do. So identify the types of intervention that will most likely affect the behavior. So is it education or persuasion? And then formulate an implementation strategy. So identify which policy options that will best deliver the intervention. So is it legislation? Is it providing guidelines, providing a service? And then construct the intervention. So fully specify the intervention in terms of its content and delivery. Assessment is at the core because at every step, as you choose, you have to assess. For example, if you choose a particular behavior, what are the other linked behavior? What's the potential spillover? If you do a COM-B diagnosis, you have to assess what other aspects may potentially be influenced. If you're selecting an intervention, you're assessing why that might work best compared to others, and on and on. So the assessment is a continuous process that you as the researcher will do together with your co-investigators, together with the stakeholders, and it's a back and forth process. You review your evidence, you go back to literature, and on and on. So I'll try to take a few minutes to explain exactly. So if you use the behavior change wheel guide, the textbook, these are the steps they advise us to do. So step 1 involves understanding the behavior, defining the problem in behavioral terms. Then you select the target behavior out of a whole set of behaviors. You select what you think is feasible for you to work on, and then identify exactly what needs to change, when and by whom. And then the next step, now you use the guide to identify intervention functions and then policy categories. And then finally is designing the content and the particular delivery of the intervention. So the first stage in understanding the behavior. What is a behavior, you may ask? Anything a person does in response to either internal or external events. So the problem, you have to define your behavioral problem in your health problem or whatever policy problem in behavioral terms. And behavior actions may be overt, so something physical or something verbal, an action, and this may be directly measurable because you may be able to observe what actions that somebody did. Did they say something, or did they write down something, or do they act in a certain way? Or they may be covert. The activities are not viewable, and these are often indirectly measurable. So I've explained that I use mixed methods to collect empirical data to identify what are the potential gaps in case detection of TB in children. And an example of a problem that we found from the empirical data is gaps in the from the hospital study. So 13 hospitals, those 42,000 children admitted, but fewer than 3% ended up with a diagnosis of TB, and fewer than 1% had documentation of use of the diagnostic tests, and gene expert and x-rays were all available in these hospitals. So there are gaps in how these children are evaluated. Now, what behavior needs to change? We thought if we could somehow document appropriately the signs and symptoms suggestive of TB in children and have a way where somebody can think through, like pathways, like if you have X and Y signs and symptoms, you need to do Z investigations, and these are your differential diagnoses. So better documentation is a key step, and all clinicians and at each patient encounter. I won't go into detail, but I had to do several pages of these matrices because once you identify a particular behavior, like documentation of history and physical signs and symptoms, there are other linked behaviors. So documentation of tests being done, documentation of samples being collected, documentation of results, documentation of differential diagnosis. And for all this to happen, you need the structured admission forms where they can document to be available. You need reagents to be available, and on and on. So everything you target is potentially linked to other things. And remember, at the core is assessing. So at each point, you're constantly reflecting together with the study team and stakeholders, what's the likely impact of this of the behavior changing. How easy is it to do, to encourage people to have better documentation? How easy is it to do? And likely spillover effect, if they're spending so much time documenting, are there other functions that are being affected? And how easy can you measure that this is being done. So if you review documents, then you can see that documentation is improving or not, and on and on. So using the guide, you have to go through several of these matrices as you try and define the behavioral problems, what needs to change by who and where. All right, so I went through that iterative process, and now the next stage is identifying intervention options, and that's by thinking through which of the combi elements could be targeted and what are the theoretical domain constructs linked to these combi elements, intervention functions, and policy categories. Basically, which intervention is most likely to change behavior. So I worked examples using the same problem. So if you think about what could potentially affect the capability, somebody's aptitude, whether it's physical or psychological, to change, we thought clinicians need to know the importance of correctly identifying TB in children. Do they have the skills to identify the key signs and symptoms and to even use them to formulate a diagnosis? What theoretical constructs underneath this? Knowledge, awareness of the steps in diagnosing TB in children. And when you use the guide, intervention functions that impact knowledge is training and to impart skills, and then modeling to provide a credible example. Somebody is competent, and a policy function through which this could be implemented is, for example, providing guidelines. And the guidelines need to be in a way that they are useful, that people can readily interpret, that if I do X, then Y, then Z. So we also identify gaps in the way our guidelines were being interpreted. When you think about the problems and how they potentially impact opportunity, so do health workers have the time to do thorough assessments? Do they have the structured forms? So that's for physical opportunity to action, and for social opportunity, culture, or providing quality of care. And the theoretical constructs include social influences. Remember the whole idea of a group living in a certain way, practices, and then intervention function work to monitoring to ensure consistent availability of structured forms for better documentation, availability of the other resources like the reagent that was coming up as a potential intervention function, where you have credible examples who are competent and people trust them and they're able to illustrate or perform the right action that could support this is regulation. So establishing principles of best practice, like this is what is expected. If you're providing quality of care, these are the minimum set of things that each hospital is supposed to be able to do to say that they're providing good care. Then when you think about the problem that could potentially impact motivation, so you remember motivation had two realms of reflective and automatic intervention. And we thought that if there's this belief that failure to correctly evaluate children could lead to misdiagnosis and death, and the theory underneath this is beliefs about consequences. Do my actions or inactions have consequences? So I'd give the example of people are not even aware the proportion of children who are being potentially missed as having TB in their facilities. So we'd present this data and then you try and discuss with healthcare workers and show them how many children die not getting care, and yet we have the drugs available. So using audit and feedback of misdiagnosis and potential adverse outcomes as a prompt to people now wanting to do better in terms of identifying these patients. And policy function that could help implement this is having regular audits, not for punitive purposes, but for quality improvement, where people have a chance to reflect on their data and see how they can improve things. So again, I won't go into details, but these are some of the matrices that I had to draw and think through and go back to my stakeholders, back and forth processes where we identify the gaps in the data, link this to the combi and the theoretical domains constructs, and then see how proposed interventions could potentially work to impact the desired behaviors. So understand their behavior, identify intervention options, and then now try and design how best to deliver the intervention. So the guide advises going through identifying the behavior change techniques, and these are just components of the intervention that sort of explain the proposed mechanism of change and the potential mode of delivery. And I'll just go back to the example that we are working on. So you remember, we're trying to impact capability. We've identified the intervention and policy functions. So the behavior change technique, which is the underlying mechanism of action, for example, for this intervention of training, is instruction on how to perform the behavior. So training just beyond, because remember I said over 600 healthcare workers have been trained, but this was not translating to practice. So we thought how the training is being delivered needs to be rethought to make it less didactic and more skills-based, with more practical sessions on, for example, how to collect the specimen, or worked examples of patients who present a certain way and how to formulate the diagnosis. So beyond just the didactic, and then still demonstrating of the desired behavior modeling by the credible people they can look up to and trust to demonstrate to them. And mode of delivery for this particular intervention could be face-to-face, either to individuals like bedside trainings, or to groups where you have a group of certain healthcare workers gathered together around a case of interest. And then use of guidelines. And did the same now for opportunity and motivation for the various gaps and interventions identified. So that now brought me to another set of matrices where now I've identified the proposed intervention. I can link it to the target behavior. I have the behavior change technique that explains the underlying mechanism. I have a proposed mode of delivery, and then I go through another set of reflection with stakeholders about now assessing things to do with affordability, practicability, effectiveness, acceptability, side effects, and equity of this particular intervention. So training program design, impacting, how healthcare workers are able to collect the specimen, for example, interpreting chest X-rays, purposeful selection of champions to provide clinical leadership, mentorship, and supervision, and then teamwork, issues to do with the social norms, and on and on. And then audit and feedback. Remember, having that sense of where you are in terms of performance enables you to set goals. And workflow restructuring. So that came up as an issue, reorganizing patient flow and processes to ensure samples are getting to the lab and results are getting back to the patient file. So simple things that can be done. And then resources, which now tend to be needing money to do, so are less effective and would need more long-term, because now this needs a lot more external inputs, but are still necessary because you need the resources, you need the guidelines, and on available for these others to be in place. So again, just going back to the steps in the designing, right from identifying the behavior, the combi, the intervention types, implementation strategy, and constructing the intervention, and each time going back and forth to assess why you're selecting what you're doing and why you think it would work. And as I conclude, I'll just present what the intervention ended up being, and in a way that this was also presented to healthcare workers as a theory to healthcare workers and policymakers as a theory of change. So the problem being the gaps in identification and investigating TB in children with the goal of improved case detection. So with gaps identified quantitative and qualitative studies, and then the intervention of training program redesign and the underlying theoretical mechanisms. So we settle on training program redesign, selecting champions, audit and feedback, and redesigning workflows as a package to work together. And these are the anticipated outputs, with healthcare workers reporting confidence, champions having defined roles, regular audit and feedback QI meetings, and then clear plans for workflows, and the short-term outcomes listed there, intermediate outcomes listed there, with the long-term outcome of increasing the number of appropriately investigated children to the TB program. So this was packaged as a policy brief that policy makers could readily consume and start to think about in terms of what they can focus on as a program to try and improve. And despite going through a rigorous process in the designing, they are not interested in the theories. They just want to see what they can do and how it could potentially work. So I'll stop there to invite questions and experiences from the audience, but just need to acknowledge my supervisors, my colleagues, who a lot of whom were part of this brainstorming, the National TB Program and the Child TB Technical Working Group, who are key stakeholders, and I had several meetings with them discussing this work that helped the purpose of designing. And as we speak, they are actually in the process of adopting some of these recommendations. Yeah, so I'll stop there. The references I mentioned are there and they'll be available with the slide.